What to do at home once you get home from total knee replacement.
This is our bread and butter. You don't eat butter anymore.
I don't.
Do you eat bread?
Yeah, a little bit.
What do you put on your bread?
Sometimes plant-based butter.
This is our whole wheat, whole grain bread and plant-based butter right here.
Peanut butter.
Peanut butter. My kid's allergic.
I know your kid's allergic.
Wild butter. So,
Okay.
what are we talking about?
So we're talking about what happens when you get a total knee replacement and then you go home. So you've got through all the preoperative stuff, you successfully navigated the surgery, and now you're at the bottom of the hospital with your walker, and you're trying to get home and go on to a successful journey and a successful knee replacement.
This is a common scenario for us because we do a lot of total knee replacement surgeries. So people are often concerned with what are they going to do when they get home.
Right. So sometimes it might be same day, or it might be the next day. Commonly at our hospital, I'd say 95% of the time it's the next day.
I mean, when do you go home after surgery? Yeah.
Yeah, you're going relatively quickly. Back when we first started practice about 20 years ago, people routinely stayed in the hospital 5 days.
And we made a video like this about 7 years ago, and we were saying, you're
I think
in the
3 at that point.
Yeah, people were in for 3 days.
Yeah.
Now you go home the same day, or you stay in overnight.
Right.
And that's tough because you got to get home pretty quick into your own home environment.
Yeah.
Freshly out of having your knee replaced. And there's some issues that you need to be aware of.
And we would say the number one thing for hip or knee replacement surgery when you're getting ready to go home is you need to have a plan ahead of time.
Yes.
Because you want to know where you're going and how you're getting there. So let's start at the beginning. How do you get home? Do you need an ambulance? Need a transfer?
Okay, that's a good point. You don't need an ambulance to get home. You can get home in a regular passenger vehicle,
right?
Like a car or minivan or SUV, but you're not going to drive yourself home.
What?
No, sir.
What if it's my other leg?
Doesn't matter.
Okay.
You're not driving home because you're going to be on medication that's going to make you drowsy and confused, so you're not alert enough, and you're going to be in some form of discomfort which will distract you from driving.
Right.
You need someone to drive you home.
Right, so you need a vehicle that's large enough that your leg doesn't have to bend in kind of weird contorted positions, maybe even on the back seat lying flat or something like that, or a larger car that has space where the seat can go back. But yes, you can go home in a regular vehicle.
And just get someone to drive you home.
Right.
Now,
we said home, but that's
well, that's true. You can go to a respite care. You can go to some other establishment for recovery.
Yes.
If you don't have anyone home or around you at home to help you.
Right.
But yeah, you're gonna get out of the hospital.
Yes.
In some kind of vehicle. It doesn't have to be a special vehicle per se.
So let's talk about home then. So can you go to your own home?
You definitely can go to your own home. So you're pulled up and you're looking at your own home. What if there's a whole flight of stairs to get to the front door?
Well, at our hospital, going up and down some stairs is one of the criteria for discharge. So this can be navigated slowly, carefully, with some intention. But yes, you should be able to do this before you leave the hospital.
Yeah, and someone in the hospital will teach you how to go up and down stairs before you leave the hospital.
Yes, ideally you're being supervised by whoever drove you to your house. You're not going to be able to take an Uber home, but they can help you up the stairs a little bit because it's obviously difficult to navigate stairs with a walker. So sometimes it's a cane and a rail or just a rail and a person, but you'll go up the stairs slowly.
Okay. Yeah, and you mentioned walker, and you likely will be using a walking aid for the first while after your knee replacement when you first get home.
What do you tell people? How long?
I tell people ultimately it's up to the physiotherapist to decide, and everybody's different. I've seen in my practice, some people after 2 weeks aren't using a walking aid, and some people are still using one for 3 months after. So it depends on your age, depends on your level of physical strength in your lower extremities, in your arms, how fit you are, and how bad your arthritis was before. There's a lot of factors that dictate how long you'll be using a walking aid after. So it's very, very variable. Don't feel like you're behind if you're still using a walking aid longer than some people that you saw in the clinic.
Sure, and I tell people, don't be in a hurry to get off of it. I'd rather have you walking further and safer with a walker than with a severely abnormal gait or an unsteady or unsafe gait with a cane or with nothing. So it is certainly very variable, but don't be in a rush.
Okay.
Okay, next.
So you've made it up the stairs if you have some to your front door. Yes. Someone's helped you, possibly. You brought your walking aid with you and you're looking at your front door. Did you bring your keys?
Well, maybe you have an app that can open.
Okay. Let's leave that part up to you and your family. But you get in the front door.
Yeah.
Now you're in your house.
Yeah.
You're looking at your house and you're thinking, oh man, my bedroom's upstairs or my bedroom's downstairs. I should have got a special bed.
Or should have bought a bungalow.
Should have bought a bungalow. Or shouldn't have on the 6th floor of that low rise that has no elevator.
Okay, so what's the deal with stairs and living or having a bedroom that's upstairs?
Okay, a lot of people ask, should I move my bedroom to the main floor? Should I get a hospital bed?
What do you tell them?
No, I think you can still go up and down stairs after, because we've taught you how to do that. That's kind of good exercise as long as you don't fall down the stairs. And thankfully, we don't see that a lot. Like I haven't had, over the many years I've been doing this, I haven't had a lot of people say, oh, I fell down the stairs.
I would agree.
It doesn't happen commonly. And people do fall, but it's not usually on the stairs. I think because you're so careful, you've got the railing and someone's taught you how to do it. So you can keep your bedroom upstairs if you want. You do not need a special hospital bed on the main floor or anything like that. I would say don't go up and down the stairs 50 times in the day like you might normally do before this experience, but it's okay to keep your bedroom upstairs.
I agree. Usually I tell people you're going to come down in the morning and you're going to go back up at night.
That's it.
But yes, ultimately though, if you feel unsafe on the stairs or just don't want to go up and down the stairs, if you wanted to have a pull-out couch on the main floor or rent a hospital bed, obviously is your prerogative, but don't feel this is necessary or obligatory.
Yeah.
Okay.
Exactly.
So now you got your sleeping figured out. You're at your own house. What are we gonna, when you go home, are you going to be on some medication?
Yeah, you're going to be on a variety of medication.
Okay.
First of all, you're going to have some sort of medication to help with the pain. Okay.
Is a knee replacement painful, Paul?
A knee replacement is very, very painful. All joking aside, it hurts a lot. And the painkillers that you are prescribed are meant to reduce the pain. There's nothing we can do to eliminate the pain.
I think that's a really good point.
Okay.
And I'd say in Canada, typically that does include, starts with the narcotic. Obviously, these are very carefully and thoughtfully prescribed in light of the opioid crisis. It is very real, but we do it in a very sensible and careful manner. But also a lot of other additional medications, so acetaminophen, potentially an anti-inflammatory of some sort like ibuprofen, and then some nerve agents we've been using more regularly, things like gabapentin or amitriptyline or whatever.
Okay, and don't worry if you feel like you're having more pain or less pain than your neighbor. The pain is always less on the other side of the fence, just like the grass is always greener on the other side of the fence. There's always going to be someone that said, oh, I didn't have any pain after, I felt great, okay? However, the majority of people have pain, varying degrees, so it's okay for you if you're having pain. Leave a comment. If you're one of those people that's like, oh, I didn't have any pain, leave a comment in there and let's see what other people reply to that.
Be prepared for some hate. And it's going to be for a while. Like it's not just 3 days of pain or 5 days of pain. This will be weeks, potentially even a month or more of pain. So you just got to bunk in for the long haul and really have a regular strategic approach.
Okay, so you're going to be on some pain medication, and then like we said, you're going to be on some sort of blood thinner.
Yeah, how come? Why are you going to be on blood thinners?
Because you don't want to get a DVT or a deep vein thrombosis, which is a clot in the veins in your leg. Not a big deal if it stays there, but if a piece breaks up and makes it to your lungs, you now have a PE, which can be fatal. A PE is a pulmonary embolism.
Right. So blood thinners can be a bunch of different kinds of medication. It really varies by location, by surgeon preference, by your own personal risk factors.
Right. Exactly.
So it could be something as strong as something like a rivaroxaban, which is a newer class of medication that we started to use, or something as simple as enteric-coated baby aspirin.
Yeah. Like you said, that varies surgeon to surgeon, patient to patient, institution to institution. Okay. So you're going to have some pills. And those those pain pills are going to make you a little bit drowsy. All right. So now am I going to be able to feed myself?
So I would say, generally speaking, yes, as long as you feed yourself before.
Okay.
Cooking and like getting up to actually cook stuff, I think can be a little bit tricky. So having a bit of a plan, maybe making some food ahead of time, or even considering one of the fancier services if you could afford it. But yeah, I think having a plan for food, I think is important.
Yeah. So meal preparation or pre-made meals or something like that is something you might want to think about, because like Dr. Weening said, you might not be able to stand around the oven and cook for a long period of time. Okay. Even in the absence of knee replacement, that may not be your thing. But with a knee replacement, certainly it's going to be trickier for you to stand there and prepare a fancy pants meal. Agreed, fancy pants. Not wearing them today. Okay, so this brings us to probably the most important part of knee replacement recovery, and that is physiotherapy. Okay, so when it comes to physiotherapy or physical therapy, the key is you need to become obsessed with it. This is, I tell people this is your job. For 6 or 8 or even up to 12 weeks, your main job from morning to night is trying to get your knee perfectly straight and then bending it as much as possible and repeating that cycle. Yeah, so range of motion is one of the most important things that we look at after knee replacement, because if you end up with a stiff total knee replacement, it is almost not curable.
Agreed.
And your window of opportunity is within the first few weeks after knee replacement.
I agree.
Okay?
Yep.
Yeah. There's a ship out there I can see. Do you see what it's called? It's called range of motion.
Yeah.
The ship has sailed after the first, month even?
Yeah, I mean, it makes you nervous. The longer you go with a stiff knee, the higher the chances it's not getting unstiff.
Yeah, that ship has sailed. So you really want to get on top of that in the first few weeks, the first month after knee replacement. And so you can't just rely on going to physiotherapy and doing that once or twice a week. It has to be done multiple times a day on your own, self-directed. You are in charge of your own range of motion.
Okay, that brings up a really great point about physiotherapy. Do you do it at your house? Do you do it as an inpatient? Do you do it as an outpatient? What's the best plan?
Yes, and yes.
Okay.
So you're definitely doing it on your own at your home, but you definitely have to leave your house and go to a physical therapy clinic or a physiotherapy clinic where they have the fancy
I got a great guy, and he's going to come to my place, and he's going to help me out.
That's fine, but you're still going to go to a
How
place.
come? Because I totally agree with you.
Yeah, because one, they have more equipment than you have at home, so they can put your knee through the range of motion.
Yeah.
Two, the act of getting out of your house and going to the physiotherapy is like 90% of that physical therapy.
Yep.
Just movement. And three, sometimes when the physical therapist or the physiotherapist comes to your house, you and the physical or physiotherapist are not as motivated to work on your knee, and you might sit and have coffee and tea rather than actually doing the exercises. I think the risk is there. Would you say? You know,
I guess I never thought of that, but yeah, that's good.
yeah, I mean, it's not as motivating.
And then for me, so in Canada and Ontario, we have a provincial health plan that covers 7 or 8 sessions.
I think it's 6.
Is it 6? I think it really depends.
Yeah.
Okay,
Oh,
so
now it's 4.
yeah.
Oh, now it's 2. No.
But what I like about that is that a lot or the vast majority of joint replacement patients are getting physiotherapy at the hospital. So they have the biggest volume of experience, and you get to be around other patients that are going through it. So there's a little bit of like a team or a community approach. So I think you need to go to outpatient physiotherapy.
Yeah, okay. And you're also going to be doing your own stuff at home.
So how many times am I doing it on my own home?
As many as you can.
That's a very vague answer. So should I do my exercises like twice? Well, that's all I can do.
I would do it more than twice. I would say, I would try and, at the beginning, you're going to be trying to bend your knee and straighten it. I would say every hour or 2.
I agree.
Just get it moving.
Okay, and then my last question is, how do we measure progress? How do I know if I'm doing okay, or if I'm behind, or if I'm ahead, or whatever?
That's perfect. We have an objective measure. It's your range of motion. We just measured in degrees, not percent. It's degrees. You go from 0 degrees.
Say I got 80%.
Yeah, 80%.
I'm like 80% of what?
80% of what?
What's 100%?
Yeah.
Because everybody's different.
Right.
That's the first thing.
So full extension is 0 degrees.
Right, so perfectly straight. So when you're lying down, the back of your knee is flat on the ground. You may have noticed if you had severe arthritis, it hasn't been doing that for potentially decades. It's called a flexion contracture. So this is really critical because your knee wants to go back to that for 2 reasons. One, because it used to be there for a long time. And 2, when you make it perfectly straight, it stretches the back of your knee, your capsule, and this is very painful. So when I tell people if they're lying in bed, don't let your leg rotate out and bend that knee, because that feels good. Have your knee perfectly straight and your toes to the ceiling, and that'll force that knee to go to the back of the ground.
Right, so if this was your knee, you must have a tough life, because you'd have to walk around in life buying a pair of pants.
I got a watch on your ankle.
That's 0 degrees, that's full extension, and then as you bend, we want you to get to at least 90 degrees. Okay? But more if you can.
Right, so let's talk about some general targets. So we see our patients usually at 2 weeks and 6 weeks, save for other complications. Right. At 2 weeks, what's our goal?
Our goal at 2 weeks is to be, I'd like to be 90 degrees before you leave the hospital, unless you're going on the same day.
Yeah.
But our goal is to be at 90 degrees, because 90 degrees lets you go up the stairs normally.
Yep.
And you lift one leg after the other. When you go on a stationary bike, you got to get at least to there so you can get that wheel right around, get the pedal right around. And I'd like to get it as close to 0 degrees as possible. Now, you might have a few degrees of flexion contracture, a few degrees of flexion is okay, but if you can get out to full, it's nice. It's nice to get out full extension, because when you're walking, your knee locks when it's in full extension. Or standing. And your quadricep muscles can relax for a few seconds. If you never get to full extension, you're always firing your quads and you will fatigue.
Right. And then so what's our ultimate goal? So again, we talked about this in some of the other videos. Your biggest predictor of your post-op range of motion is your pre-op range. So if you had a really stiff knee, your goals are going to be different. But for the average person, what are you happy with? At 6 weeks, if they come in and they have X number of degrees, what makes you the happiest? Obviously the most, but I mean...
Yeah, I like it if they're first of all, if they're as good or better, as good as better than they were pre-operatively,
Sure.
that'd be amazing.
Yep.
Especially if they had a stiff knee before. But I just want them to be, over 90. If you can get to 100, 110, that's amazing.
Yeah. I like to push people at least to 110, but again,
Yeah.
everybody's a little bit different.
Yeah.
Okay.
Okay, so complications to watch out for when you're at home.
Okay.
All right, so you made it home. We figured out how you're going to get in the door, how you're going to get to your bed, how you're going to eat some meals, how you're going to do your physical or physiotherapy. Now, you have to be vigilant and look out for some complications.
Okay.
Big bad things are infection.
Okay.
So if the wound's getting red, more red than it day by day, more swollen day by day,
Yep.
or some kind of drainage that's not getting less and less,
Yep.
more pain day by day,
Yep.
those are things that can indicate that you might have some kind of infection.
Totally agree. Why don't you, as surgeons, why don't you just give me a whole bunch of antibiotics I can go home with to prevent that infection?
Oh, yeah, that's a good point. However, we don't like to give antibiotics willy-nilly because then we're going to be promoting resistant bacteria.
Right.
Okay, so it's dangerous to just prescribe antibiotics without actually treating an infection.
Yeah, studies have shown that less than 24 hours of postoperative antibiotics are required to reduce your long-term risk of infection. And going beyond that doesn't necessarily make a difference.
Yeah. Okay. So you're going to watch out for infection.
Okay.
Another major complication to watch out for is the deep vein thrombosis
Right.
we mentioned earlier. So if your calf is getting really, really painful in the calf and
Yep.
really swollen and tight, now you're going to get swelling. Everyone gets swelling after knee replacement. That's just the way it is.
Yeah.
But if you're getting worsening swelling and increasing pain in your calf, that could be an indication that, hey, maybe you have a deep vein thrombosis.
Yep.
Come to the hospital, get an ultrasound to see if there is a clot there. Remember, because a piece can break off and go to your lungs.
So if you do have those complications, so if you, heaven forbid, have chest pain or shortness of breath, that is a sign you may have had a clot that has gone to your lungs, and definitely that's straight to the ER.
Right.
Before we go to the next one, let's talk about swelling. Is there anything that we can do to help reduce our risk or the amount of swelling that we have?
Yeah.
Because that definitely limits your ability to bend your knee.
Rest, ice elevation, that'll help.
Compression.
Compression.
Yeah. And that includes things like just ice packs or even commercial ice machines where they either circulate cold water from a little computer right through a bladder or even some that compress.
Yeah. So, and then the other complications that are all associated, heart attack, stroke, death, blood clot, infection, pneumonia, those kind of things can happen too after surgery. So be vigilant for those kind of things as well.
Okay, so I'm trucking along, really happy. My pain's controlled, my range is coming. I've got rid of my ambulatory aids. When can I go back to work? Because I really love my job.
Okay. So that depends. That totally depends,
Okay.
right? It depends on what your job is and how much you like your job.
So I have a physical job, and I like it.
Yeah. Okay.
I'm a farmer. How about
Okay,
that?
and then it also depends. Are you self-employed, or do you have some sort of income that you can receive even while you're sick at home or recovering at home?
Scenario number one, so you have really good benefits, and your benefits say you can be off for 14 weeks.
Yeah, I would say 3 months. I generally tell people 3 months.
Yep.
If it's a really physical job, it's 3 to 6 months.
Yep.
If you're working from home or you're self-employed, or you can get someone to do some of the heavier labor, it's 2 weeks.
Right.
You'll go back
The
in 2
caveat for that is that we just don't want you to go to work and be working 14 hours a day and not doing your exercises. So it's at the expense of the time that you're normally going to spend doing physiotherapy at home.
Yeah.
You want to make sure that there's a balance there, and your number one job is to make sure you have a good knee for the rest of your life, not to get back to work at 6
Yeah,
weeks.
you deserve a bit of a recovery period,
Yes.
so take a break from work after your knee replacement. Schedule things appropriately, but take a break. It's some me time. Enjoy the me time.
Okay.
The me time with your knee time.
Okay, me time with a knee time. That's a nice segue. So I'd like some me time. I like to get on a plane for some me time and go on a trip.
Okay, I mean, I generally say 3 months.
Yep.
But some people go earlier, some people like to wait longer. The risk is if you go on a plane, again, it's that blood clot risk that we worry about because you're up in an aircraft with the cabin pressures less than atmospheric, so that can pool some blood. Even if you've never had a knee replacement, you can get some swelling or a blood clot when you go up in a plane. For
sure.
So at least 3 months, we generally say.
And make sure you talk to your travel insurance company. Make sure that there's not a caveat that says you now have a pre-existing condition, often for 90 days, even if you change a medication of some sort. Make sure that you're going to be covered for anything related to your knee replacement.
All right.
Okay, what else?
That's it. I'm done.
What about sports?
Sports, yeah, if you're into sports, which everyone should be for some kind of athletic or your exercise, returning to your exercise. It depends on your sport, depends on your exercise, right?
Yep.
Most commonly around here, people want to return to golf. Which, I say you're going to ease back into it somewhere at the 2 to 3 month mark.
Yep.
You're not going to go in for the long drive. You're going to sort of just be chipping and putting first, and then back fully after about 3 months.
We can include a video on how to fix your slice that we worked with Dr. Sells on the summer.
Don't get me started.
Okay, and then the last one is, so now I'm back to sports and traveling. What about, my other knee really bugs me. And I want to talk to you now about when can I do the other side? I've got over the trauma and the stress of having my knee replaced. I want to do the second side.
I tell people, hey, sometimes you don't even need to do the second side because the pain goes away when you have one good leg.
Yep.
Or you might hate it so much and you are one of the unfortunate people that lands in the category of persistent knee pain after knee replacement, which is about 1 in 5 people. You may not ever want to do the other side.
Ballpark for the shortest?
3 months.
3 months, I say the same thing. And that's not necessarily based on specific science, but we feel that adequately allows you to recover, get your life back in order, get your hemoglobin back up. It does take about 8 weeks to make new red blood cells, so that gives you a ballpark to do that second side.
All right.
That's a lot.
That's a lot.
I feel like I'm ready to have a knee replacement now.
Congratulations if you made it to
the end of this video.
And we just want to do a video that's really our bread and butter or pita and hummus of what we do.
Okay, if you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health.
We'll see you next time.